All right, let's begin. So, welcome everybody to our discussion on branching out, getting the most of your OCTA. My name is Mark Dunbar, and I will be moderating this session. I'm joined by two outstanding faculty members, both very good friends. In the middle there is Jessica Steen. Jessica is a faculty member at the Nova Southeastern University College of Optometry, and Carolyn Majcher is a faculty member at Tahlequah, the optometry school in Oklahoma. All of us are very familiar with OCT angiography, so I'm excited about really having a great discussion. We're going to share some cases. We'll talk about interpreting OCT, and really the goal is to generate some good discussion among all of us around OCT angiography. This is a promotional program. It is not meant for continuing medical education, though I will say the content is going to be so good that you're probably going to wonder, why aren't I getting CME for this? And the reason, in part, we are here as consultants for Carl Zeiss, and this will be focused on the Cirrus OCT angiography device. Um, and so we really have seen incredible advances around OCT technology. I mean, if you look at really almost 1999 to 2000, really the very first OCT that was used was at Tufts University in Boston, and that's the upper left. And again, a crude device or a crude image, but you were looking at about 100 axial scans per second to really generate a decent retinal image of a patient with a retinal pigment epithelial detachment. But it really wasn't until the Stratus in around 2001, 2002, maybe 2003, where we had really the first commercialization of OCT. And sadly, I was around when the Stratus was, really developed and being used, and that was really our foray into OCT at the Bascom Palmer Eye Institute. So we went from 100 axial scans to about 400 axial scans, and it really was a game changer because for the first time we could, get cross-sectional images of a retina, a scan while a patient was in the chair, and really for the first time really understand a lot of diseases that we really maybe didn't quite understand before, such as full thickness macular holes and vitreomacular traction. And then in 2007, of course, we advanced to spectral domain OCT. And so we went from 400 axial scans to up to 35,000 to 70,000 axial scans, which give us this beautiful high resolution image. And now you look at where we are today on the bottom right, where we're looking at OCT angiography. So we went from 70,000 axial scans to over 100 axial scans a second. And if you looked at that image, gosh, compared to whatever the traditional fluorescein angiography was, and you can see this is a much better, higher resolution image. And so OCT angiography really is a non-invasive, dye-free way of visualizing the retinal vasculature in vivo. So we went from, as I said, 70,000 axial scans to over 100 axial scans. And the idea with OCT angiography is when you're scanning the same area in the retina over and over and over again, what you're able to do is capture motion. And what we were able to do is capture the motion of the blood vessels, the red blood cells, as they move through the blood vessels, and thus gives us really this beautiful OCT angiography view. We started at a scan size of about 3 millimeters to 6 millimeters, and where we are today of a scan of about 12 by 12 millimeters. In this scan, you're able to view from really one arcade to the other. So this three-dimensional image is obtained depicting the microvasculature, the superficial, deep, and avascular layers of the retina, and we'll demonstrate various cases as we go along. What I think makes this particularly interesting in where we are today in 2025 is that there is now a new CPT code that allows separate reimbursement for OCT. When you looked at traditional OCT imaging, it was about $31. And again, this may vary from state to state and region to region, but now you look at OCT angiography and the new CPT code 92137, and you're looking at an average reimbursement of almost $57. So all of a sudden, it makes this modality, I think, more interesting, more clinically applicable. And again, from an optometric perspective, I would say that we were very quick to get on board because OCTA really allowed us for the first time the ability to really look at microvasculature. We've been great at recognizing disease pathology like macular degeneration, obviously grading diabetic retinopathy and retinal vein occlusions, but for the first time, we're really able to see what's happening on a vascular level without needing to inject a dye like uh, traditional fluorescein angiography. So you look at the benefits, right? Managing patients with diabetes and other retinal vascular disease. These are really within the wheelhouse of optometry. Managing patients with dry macular degeneration and really being able to detect very early that conversion from dry AMD to wet. I haven't used it much in the glaucoma setting yet, but I think you'll recognize that there's certainly opportunities around glaucoma with OCT angiography. It allows for better referrals to retinal specialists. I've always say what OCT and OCT angiography has done is it's really leveled the playing field among eye care providers and subspecialty ophthalmologists. When you send a patient to a retinal specialist anymore, it's not because you don't know what's going on. Again, I think are good at recognizing disease pathology. And again, 20 years ago, before ACT, OCT, we would send these patients along, maybe not really knowing what was going on. Now with OCT and OCT angiography, it's not that we don't know, it's usually because this is a patient who really needs to be treated, be it a patient with diabetes, a retinal vein occlusion, or a patient with macular degeneration. And you look at the added reimbursements around OCT angiography, and I think this really makes an important modality for the primary care optometrists. I like to show the scan as we go from the superficial retina through the middle retinal layers into the choroid and retinal pigment epithelium and choroid. This is a classic example well, I thought we were going to see a patient who's got choroidal vascular membrane. We don't have it in this one. But again, you look at the overlay here, the scan looking at the ORCC, the outer retina choriocapillaris, and you can see this little hyperfluorescent area that's very typical of a patient with choroidal neovascular membrane. And so, one of the things about interpreting, right, there's a lot of information on these OCT angiography printouts. And what's nice is, at least on the Cirrus 6000 and really all the Cirrus OCT devices, you've got these pre-built en face slabs that allow you to quickly look at a printout of an OCT angiography and kind of zero in on what's important. And this is a patient that will look at the color images in a little bit, but it's a patient who had a retinal vein occlusion. They came in as a referral to rule out diabetic retinopathy. This is a patient that was seen 1 year earlier. And again, what is interesting is no, you don't see any diabetic retinopathy, but when you look in the superficial layers, particularly superior, you see a large area of low flow or capillary non-perfusion. And as it turns out, this is a patient who's had a retinal vein occlusion, despite the fact that they're 20/20, they don't have really any other retinopathy features other than what we see on the OCT angiography. So again, these pre-built en face slabs, I've kind of highlighted it in orange, letting us look what's happening, depending on what layer of the retina. Here's another patient of mine that, again, we'll look at the color images in a little bit. A poorly controlled patient who has diabetes, tough to get him in. And finally, after a couple of years, he does come in. And again, what you see is this is a 12 by 12 printout. We're looking at the superficial retina. And I think you can see very nicely the area of neovascularization along the inferior arcade. You also are able to see areas of, again, of low flow that represents capillary non-perfusion. Now, if you're used to looking at these, you'll recognize that this isn't the best quality scan. This is a patient who was a poor fixator. He had constant movement, and it was very difficult to get an image. But again, with the Cirrus 6000 scanning at over 100,000 axial scans a second, I was really impressed that we were able to get the quality image that we were. So again, we're kind of highlighting that area in orange looking at the superficial retina. And so I think the nice thing about OCT angiography is we are able to look at the superficial retinal capillary plexus, the deep capillary plexus, and those show up very nicely on your OCTA printout. So again, in a patient who has diabetes or a patient who has a retinal vein occlusion, you can kind of zero in on the area where there's pathology. And again, you're looking at, this is with the Claris fundus photo, looking at a wide field image. And you could easily miss that area of neovascularization inferiorly. But again, the OCTA, I think, complements very nicely what's happening with this patient. And of course, having neovascularization and proliferative diabetic retinopathy, of course, we sent him off to the retinal specialist. Here's a couple of other examples of patients who have diabetic retinopathy. And again, I'm not showing the little slabs, but I think you're able to recognize this is a 3 by 3 scan, and then the same patient kind of backing off a little bit on a 6 by 6 scan. So again, I think what's nice in these patients who have retinal vascular disease, and again, I'll let Carolyn and Jessica please chime in here, right? As optometrists, we were great at recognizing the presence of diabetic retinopathy, but for the first time, we're really seeing what's happening on a capillary level. You see some widening of the capillary free zone. You're seeing areas a little bit more peripheral where you're seeing capillary dropout and low flow. Any comments, ladies?
Yeah, I couldn't agree more with you, Mark. I think it's really important to use OCT angiography or some form of angiography to look for macular ischemia because clinically we can't see that, but it may be causing decreased best corrected acuity in a patient that doesn't have diabetic macular edema. I'm just always so amazed when you take an OCT angiography scan, how it really highlights these like subtle vascular pathologies like IRMA or like you said, preretinal neovascularization that otherwise we really can't see clinically sometimes.
And this has really called into question our current staging systems for diabetic retinopathy. We understand that there are subtle vascular changes that we see before there is clinical diabetic retinopathy. So as we're finding these subtle areas of capillary dropout in large foveal avascular zone in early cases, really the question becomes, how do we best manage these patients? How do we best classify these patients? And when we talk about management, certainly that in these early stages, it truly is with the managing systemic physician involved as well.
Yeah, and you can look on the B scan. This patient doesn't have diabetic macular edema, so we're getting really the best of everything. We've got the nice B scan showing the normal retinal architecture, but yet on a microvascular level, you're starting to see diabetic retinopathy changes that, again, prior to OCTA, we just wouldn't be able to see. Your comment was very good about staging of diabetic retinopathy, and you guys are probably aware of the Mary Tyler Moore initiative, really looking at restaging and reclassifying this disease that, let's face it, hasn't been done since the early to mid 1980s, way before we had this kind of technology available. So obviously long overdue, and we will see into the future, I guess, how these technologies help shape our classification and then ultimately management of patients with diabetic retinopathy. Here's again a not so subtle case of a patient who's got PDR. They've already had laser. And this was probably the first 2 or 3 months that we had our OCT angiography machine about 8 or 9 years ago. And again, I was just so impressed with, instead of having to inject a dye, and which obviously in the state of Florida as an optometrist I wasn't able to do, but yet in a matter of a few seconds capture a beautiful image of really on a vascular level showing neovascularization. Adjacent to that area of neovascularization, once again, you see capillary non-perfusion. So really, really remarkable to be able to capture that with an OCT angiography image. Here's one, right? We talked about some of these patients who've got retinal vascular disease and how important it is to really look at some of the superficial retinal layers. Here's a 17-year-old who, a friend of my daughter, surprisingly, and it's at the end of school in their senior year, and all of a sudden, she's got this sudden change in her visual acuity, and she describes this paracentral area of a scotoma. And of course, she's got this rare condition, paracentral middle acute retinopathy. And so when you're looking on the clinical photo, right, this little area of whitening that represents probably a little focal area of ischemia. We look at our OCT B scan, and again, within the middle layers, you're seeing a higher reflective area. And again, look at our near IR image, and you can kind of map out this little area where it's darker. So a lot of information on our traditional OCT scan, but yet when we go to OCT angiography, and again, we're looking at that outer retinal choriocapillaris area, that middle retinal area, if you will, and we show this little focal area of ischemia. So again, a really nice feature with OCT angiography, not just looking at the superficial retinal layers like you would in a patient with retinal vascular disease, or the outer retinal layers like you might in a patient with macular degeneration who's converted from dry to wet. But here's really a great example showing really looking at the middle and outer retinal layers in a case of a patient who's got paracentral acute middle maculopathy. And again, some more of these scans kind of highlighting that very nicely. Again, looking at the typical macular degeneration, and this was, again, probably a month after having our OCT angiography device, I saw this lady, a 92-year-old who's 20/40. And again, traditionally, we would get traditional OCT, but having OCT angiography, I was kind of this area in the right eye where you see this little reddish area. I couldn't tell if it was a focal area of subretinal hemorrhage. And so, again, being able to do an OCT angiography proved to be very beneficial. You see the modeling, you see some drusen, you see that little area of red there that, keep in mind, she's looking through an implant, she's photophobic, she's moving, and you're not getting the best view. But yet, here's our OCT B scan showing this nice kind of double layer sign that's really pathognomonic of an occult choroidal neovascular membrane. And then when we do our OCT angiography, it really showed it very, very nicely. And this was the patient who kind of was the wow moment for me, really utilizing a technology that otherwise we probably wouldn't been able to see what we were able to see without having to, do an injection and, sending her off to a retinal specialist, etc. And so again, looking at a couple different scanning sizes, a 6x6 scan, gives you a little bit of a wider view versus the 3x3. And that area of red that I was looking at, that was the trunk of this neovascular membrane. Now, they don't always look this obvious and beautiful, and I know, Carolyn, you're probably going to show us some cases where they're much more subtler, but again, when they show up like this, I think it's really pretty incredible. And so again, particularly when you're looking at the Cirrus 6000, 100,000 scans a second, 270 times faster than traditional OCT. You can get an OCT cube in about 0.4 seconds, which is just really kind of mind-bogglingly fast. Again, we looked at different scan sizes from a 3x3 to a 6x6, even up to a 12x12, looking from arcade to arcade. So again, a lot of information in an easy-to-read printout. And again, just looking at a couple examples of what a normal OCT angiography would look like, and we'll go dive into some cases here in a little bit. I showed these images. I'm going to move very quickly. This was a patient I saw who was a diabetic, who was seen a year ago and was completely normal. And so he comes in for his annual diabetic retinopathy screening. He's got a well-controlled, actually, he has a well-controlled A1C now. It wasn't always so good. But again, you're looking with this Claris wide field image, this area of capillary what we assume is capillary non-perfusion, these kind of sheathed and sclerotic vessels that again you can kind of see on a vascular level changes here. And again, the color photos show it very nicely. I wish on my OCTA I would have had the photographer scan a little bit higher in the retina. I think we would have got a better image. But I think it shows a great example of a retinal vein occlusion in a patient who's got capillary non-perfusion. This is a patient who I'd followed as a glaucoma suspect, but she came in on a visit a year later, and again, looking at normal OCT RNFLs with a change of 20/70 visual acuity. You see this little spot of subretinal hemorrhage. And again, the B scan shows retinal thickening and a little bit of fluid. And so again, just really highlighting the importance of being able to do OCT angiography. So we look at this kind of avascular area where you're starting to get some area of hyperfluorescence. Remember, this is an area that should be black. You shouldn't expect to see any hyperfluorescence. And then when we move a little bit into the outer retinal layers, you see this nice lacy choroidal neovascular membrane that ends up being, in this case, idiopathic because she didn't really have any drusen, but yet obviously she fits the age group of being macular degeneration, but really didn't have it. Carolyn and Jessica, before I turn it over to you guys, I guess, Jessica, you're next in line. Do you have any comments? This is a patient, of course, I did refer to a retinal specialist. They do end up, and this is a 6x6 scan, by the way, we're taking a little kind of wider view of it, and they end up having multiple anti-VEGF injections, unfortunately, never really improve beyond the 2150 when after having multiple injections.
I think something interesting is you showed that first choroidal neovascular membrane. I think we probably all remember the first choroidal neovascular membrane that we visualized on OCTA. Thinking about the structure of the membrane itself is something that fluorescein angiography just doesn't image. So
Yeah.
truly, understanding the true structure of a membrane, I think is so interesting. It's fascinating to see and something that I think never really gets old.
Yeah, it really doesn't.
I couldn't agree more with you, Jessica. Like, that's what I love about OCT and geography is that you're able to directly visualize the neovascular nets themselves, not just the secondary effects that we're used to with structural OCT, like fluid or pigment epithelial detachments. This is a great case, Mark. I think what I would point out is that I tend to really favor the ORCC now over the avascular slab. I think it just has so much more to offer, and we've gotten rid of projection artifacts for the most part. And so if I'm looking for a patient with neovascular AMD, like the ORCC is where it's at. And, there's so many presets, I think, sometimes on the sides, and especially I work with students and residents, they get confused as to like, what preset should I be using for what? Like the workhorse presets that I use are the vitreoretinal interface to look for pre-retinal neo, say in like proliferative diabetic retinopathy, then the superficial and deep capillary plexus, like you pointed out, for interretinal disease like diabetic retinopathy, retinal vein occlusion, and then the ORCC being like the workhorse for any sort of outer retinal disease like macular degeneration, central serous, etc.
Yeah. And I think with that, Jessica, let me turn it over to you.
Thanks, Mark. So we've had just an excellent overview, Mark, on OCTA and how we think about incorporating it. Now I'm going to go into a couple of cases that really highlight exploring unexpected findings and how OCTA can help us to understand some of these unexpected features that we see in patients who may present for another disease process. Now, this is a 70-year-old black male who had presented for evaluation of suspicion of glaucoma. He has type 2 diabetes mellitus, and he manages his condition with diet and a medication or a treatment that I had to look up. It's called Amiclear. This is something that is purchased on Amazon as described as being a supplement that's taken orally as in liquid form. Again, we're thinking about the medications or treatments or vitamins that our patients take, and there always seems to be something new or unexpected. His corrected acuity is 20/40 and 20/30. He doesn't have an afferent pupillary defect. Pressures are within a typical range with a fairly average central corneal thickness. Now, this is someone who, yes, has nuclear sclerosis, but I wasn't sure that the nuclear sclerosis described or completely accounted for the best corrected vision of 20/40 in the right eye. So the next step in this patient was to better understand the reason for the reduction in vision. We see the difference in our clarity looking in. Clinically, the macula looked unremarkable, and maybe this is just related to the nuclear sclerosis the patient has. Interestingly, inferior in the left eye, there's a focal retinal nerve fiber layer defect that we can visualize. Now, if we scroll through the OCT in this patient's right eye, when we get to the center of the fovea, there is this area of a cavitation. There's no significant epiretinal membrane, but we see this draping of the inner limiting membrane with this focal cavitation. Now, I see this, and my next thought is, could this be early macular telangiectasia? Now, when we're thinking about MACTEL, especially in early cases, yes, we are looking at this almost enlarged, elongated foveal avascular zone, but OCT angiography can be truly helpful in identifying early features, especially when the external limiting membrane, the outer retina, is not involved. Remember, we're thinking about MACTEL. This isn't a vascular condition, although it affects the vasculature. It affects the Mueller cells, so this is a neurodegenerative condition. With the new focus is having an FDA-approved treatment for macular telangiectasia type 2. This has also changed the way that I think about assessing patients and identifying patients who may be a candidate for a treatment. Now, The OCTA, if we look at the superficial capillary plexus, again, I'm focusing on the area temporal to the center of the fovea. There doesn't appear to be, at least in the superficial capillary plexus, any vascular anomaly that I would expect in macular telangiectasia. Something interesting, depending on the platform that you use, this is utilizing Forum. We can work through each of these angioplex presets. I'm starting in the superficial capillary plexus, and I can move into the deep capillary plexus very easily. Now, what we're seeing is the superficial capillary plexus with an overlay of the patient's retinal image. Moving into the deep capillary plexus, this is really where I'm carefully assessing for any subtle deep vascular changes. Again, looking in the area temporal to the center of the fovea, there doesn't appear to be any focal dilation or change in the vascular structure that I would expect in a patient with early MAC-TEL. We can magnify this more, again, looking at the area temporal to the center of the fovea. Now, in that patient's case, I'm looking for a vascular change that was ruled out by OCT angiography. Now, that's a patient who certainly is pending cataract surgery. This is the only reason for reduction in vision in that right eye is nuclear sclerosis. But this is someone that I'm watching and will watch every 6 months. Could that still be very early MAC-TEL? And is there going to be Mueller cell loss and vascular change that develops later on? Now, another case here, just to think about the unexpected findings. This is a woman who has glaucoma, and to think about the other conditions that are demonstrated in individuals who have glaucoma at a greater likelihood. She has been lost to follow-up since 2019. She has hypertension. And she has not had treatment for glaucoma in at least 4.5 years. Pressure, when I had seen her, peak pressure, now untreated pressure, 32 and 33 millimeters mercury with thin corneas. Gonioscopy, always important in these cases, unremarkable. Now in 2019, we have excellent fundus images of the right and left eye. And as I'm updating the fundus photographs, generally once a year for patients who remain in care, I'm not just looking at the photographs on that day, but always comparing the patient to themselves over time. Now in 2025, the current photographs, the first thing that stood out to me in comparing this patient to herself is, especially in the left eye, the area of the nasal optic disc. There's the development of collateral vessels. Again, this is a change that we've identified. And clinically, when I look at this patient, what I had seen in the the superior arcade in the left eye is that there almost seem to be these little aneurysmal changes or little vascular changes that, again, OCTA was where I turned to help me better understand what the vasculature changes truly are. And what we see in looking at the superficial capillary plexus, number one, are these areas of capillary dropout and vascular remodeling that are very apparent when we look at the deep capillary plexus. So really, the superficial capillary plexus certainly helpful in looking at capillary dropout, but really when we're looking for vascular remodeling, the deep capillary plexus is the other area that I'm interested in. Now, what about those collateral vessels, that connection into the deep choroidal vasculature? Again, finding where those vessels are located. Again, they're much deeper than what you may expect clinically. This is really a customized profile or slab in looking very deep to be able to image the collateral vasculature. Now, this patient has had a retinal vascular occlusion. At first, it seemed like a branch retinal vein occlusion, but when we explore this patient in a montage image and an even wider field image, we can see that this is truly a hemiretinal vein occlusion that the patient has. And I think really in this montage wide field image, this is where we really get an understanding of the widespread vascular changes that this patient has developed asymptomatically at some point in the last 4.5 years.
And we've highlighted, over and over already, just the fact that clinically you don't really see it and appreciate it. And yet with the image like this, it's like, how could you not see it, right? And it just tells such an important story. And again, just prognostically, I don't know if they have a great risk of neovascularization, but just the fact that they've had a major, retinal vascular event that otherwise nobody would have been able to discover is remarkable.
And that's the key, I think, for me in this case is thinking about what do we do next? Well, this is a patient who has reported well managed hypertension. But when we're thinking about risk factors from a systemic perspective, this is someone who clearly needs to have close care, close monitoring, close management with their systemic physician. Now, here's the other interesting piece. Then I went back to the right eye and said, it looks like there might be a little collateral vasculature that's developed in the right eye as well. In the superior arcade, those same dilated, almost aneurysmal changes. This is a patient that had bilateral, asymptomatic hemiretinal vein occlusions that, again, we're finding as essentially an incidental finding and following that clue, following that curiosity that we see clinically. These are the pieces, these are the cases where OCTA in a primary care setting can really help us to understand, to describe, and think not just about the retinal findings, but the systemic risks as well.
Jessica, that was such an excellent case. I want to point out too, like how that's going to affect your glaucoma assessment, because that's going to cause some nerve fiber layer loss superiorly in the location of that like branch retinal branch vein occlusion. And so it's important to kind of like know that that's going to affect your analysis when you're thinking about glaucoma. And I can't tell you how many like of these subtle like subclinical retinal vein occlusions I've also picked up on patients, just checking for glaucoma or we're scanning for diabetic retinopathy, and you happen to see these telangiectatic vessels that really clue you in that there's a retinal vein occlusion present. What else?
You brought up that is such an excellent point, Carolyn. That is something, no question. There is a retinal nerve fiber layer defect there. It's in the area where we expect glaucoma to impact the optic nerve and, again, the retina. So, carefully being able to differentiate what is due to retinal pathology from what may be due to glaucomatous optic neuropathy is so key. And OCTA really helps us to highlight that in that case.
The other thing I love about OCT angiography and retinal vein occlusions is like, let's say you have a patient with just some arterial sheathing or attenuation, and maybe it's the artery and the vein, and you're trying to say, did this patient have an arterial occlusion problem or a vein occlusion problem? Because your systemic evaluation of those two entities is going to be very different. And when you see those like dilated sort of telangiectatic capillaries in the deep capillary plexus, like you pointed out, that really helps nail it down that this is a vein occlusion, and I don't have to do an embolic evaluation on this patient.
Great cases.
Great. So start off this discussion introducing a case of the utility of OCT angiography in central serous and pachychoroid spectrum diseases. So this was a 39-year-old male, and he was coming to me in my clinic as a 2-month follow-up to ensure that there was resolution of fluid following an active episode of central serous chorioretinopathy. And so 2 months ago, we can see on his OCT scan, he had some active subretinal fluid that we think was precipitated by a steroid injection that he had into his shoulder for pain. And anytime I see a patient that has any sort of active pachychoroid spectrum disease, always asking about steroid use, I think is really important, as well as stress. And he did report some stressors with his wife transitioning jobs or losing her job recently. And then just their sleep cycle, like, are you working nights, etc. And he said, because of the shoulder pain, he's been having trouble sleeping. And of note, he also has sleep apnea that he's been using a CPAP for the past year. And any patient that has issues with sleeping too, there's some interesting evidence right now with melatonin potentially being valuable in patients with central serous chororetinopathy. So I'll usually ask a patient, have you tried using melatonin to assist with your sleep cycle? And he said he's tried it, but it's knocks him out so much that he can't get up for work the next day. So he hasn't really been successful with use of that. So his interesting best corrected acuities on the examination where I'm seeing him 2 months later, 20/20 -1 in the right eye and then 20/20 in the left. Here's his color fundus photography and then fundus autofluorescence in the right eye. And this is the current examination, so the 2-month follow-up where I'm seeing him. And on the color fundus photography, we can see there's some hypopigmentary changes of the RPE in the temporal foveal region. And what I love about fundus autofluorescence in outer retinal disease, especially like pachychoroid spectrum diseases like this, is that sometimes you can really light up so many RPE pathologic changes that we couldn't see on the clinical exam. So I think a clinical pearl that we can kind of stop here and note is any outer retinal disease like central serous chororetinopathy, macular degeneration, utilize your FAF. I think we're not using it quite enough. But on FAF, we can see there's some like hypopigmentary type of alterations that correspond to these hypopigmentary changes on color fundus photography here. So in Zeiss Forum, I'm in the retinal workplace. We're able to actually overlay our 21 line raster scan on top of our color fundus photography. So I can really localize OCT pathologic findings to what I'm seeing on color fundus photography. You could do the same for fundus autofluorescence as well. But in this patient's right eye, we can see he's had resolution of that subretinal fluid in the subfoveal space, which is excellent. So, the natural course of central serous is for that subretinal fluid to resolve on its own, which it has done. But what we do still see is this sort of multi-lobed serous pigment epithelial detachment present. What else we can tell about the RPE integrity from this OCT scan is that we have some areas of like choroidal hypertransmission here, which correspond to some discontinuity of the RPE, suggestive that this pigment epithelial detachment is probably chronic in nature. It's been there for some time. And then, of course, the highlight of pachychoroid spectrum diseases like central serous is going to be the pachychoroid, right? So we have this thick choroid with a lot of boggy fluid, especially in the posterior aspect. Here's the Zeiss Forum Retina Workplace macular thickness analysis that I've selected here. And what this allows you to do is to compare either 2 or 3 serial OCT cube scans, and you can actually like scroll through them in synchrony, which is really nice to look for changes over time. So we can see his initial baseline examination when he got that steroid injection, how he has this subretinal fluid. And then on today's visit, we have resolution of that subretinal fluid. The pigment epithelial detachment looks relatively unchanged compared to 2 months ago to today's examination. Here's the 3 millimeter OCT angiography scan of the right eye. And like I said before, the outer retinal choriocapillaris is really where it's at when we're looking at outer retinal diseases like pachyspectrum types of diseases or macular degeneration. And so we can see in the right eye, there's some rarefaction of the choriocapillaris present, but there's no neovascular membrane within that pigment epithelial detachment. So I can rest really confident here that there's no neovascular complex present in the right eye. But of course, we're going to look at the left eye of this patient as well, since pachychoroid spectrum diseases tend to be bilateral changes in nature. And so here's the color fundus photography as well as the fundus autofluorescence of the left eye. Remember, he's 20/20 vision in this eye. There's some pigmentary alterations, not only in the central foveal region, but also kind of superior temporal here as well. And we're able to really highlight those areas of outer retinal RPE pathology on our fundus autofluorescence imaging. Here I've again overlaid the 21 line raster scan on top of my color fundus photograph in Zeiss Forum Retinal Workplace. And what we see is this goes by so many different names. So I know, Mark, you called it earlier like a double layer sign. Some people call this a SIRE, a shallow irregular RPE elevation. But the double layer refers to one layer being the RPE and then the bottom layer being Brooks membrane. So you have this shallow, kind of lumpy, bumpy contour pigment epithelial detachment. And when we look at the internal reflectivity of that, it's kind of like a medium reflectivity. So we know there's not this like fluid in that sub RPE space. There's perhaps some sort of neovascular membrane. So I think, again, like just pause for a second and say, this is a really great clinical take-home moment when we have this double layer sign or this SIRE lesion. Even if you don't have angiography, you should suspect in this patient that there is an occult or type 1 neovascular membrane present. But of course, since this is an OCT and geography lecture, I'm going to show you the beautiful 3 mm OCT and geography scan. And this is the outer retina choriocapillaris, where we're looking at any blood flow in the photoreceptors and then down into the anterior choriocapillaris. So we're highlighting this area of neovascularization, which is located in this shallow pigment epithelial detachment. What else I want to point out here too is, I love the NFOS displays, but then I always double check what I'm looking at by looking at the B-scan overlay as well. So I can actually see that there is a red overlay of the material within the pigment epithelial detachment, which is telling me this is a vascularized pigment epithelial detachment. Definitely type 1 neovascularization. So what are we going to do for this patient? Fortunately, the subretinal fluid has resolved in the patient's right eye, but he still has this pigment epithelial detachment. So for me, is like borderline, do I want to consult with retina because there is this chronic PED? We really don't have great treatment options available for that. So it's probably a conversation I would have with the patient, especially since our retina specialist is so far away living in a rural area. But I'd feel comfortable observing the right eye. The left eye is a similar deal. We have this neovascular membrane, but there's no fluid around it. There's no hemorrhage around it. So there's nothing that we need to do about it at this time. But I think it's important that we know it's there because there is a potential that it could become active in the future and become exudative, leaking out fluid or leaking out blood. So giving this patient an Amsler grid, I think, is very important. Talking to him about avoiding steroids, if at all possible. And then, maybe trying the use of melatonin, again, to prevent recurrences of central serous in the future. Mark and Jessica, any comments on this case?
Beautiful image, and the fact that that membrane is really so small, and that you're able to capture it. Like the one that I showed that was bigger, which again, similar circumstance, but when I referred it to the retinal specialist, like this one, they didn't treat it. With the idea that that membrane is probably providing some nutritional support, to the retina, and the fact that it's, there's no architectural significant damage, that I think it makes sense, especially where you're at, where, access is not great to see a retinal specialist. I think it's reasonable just to watch it.
I think that's the biggest thing through the last 10 years is what we've better understood about management strategies as we're finding lesions that existed, but we may not have known about previously. Early on, we had a lot of discussion about how do we manage these non-exudative choroidal neovascular membranes. And, you brought up the excellent point in this case that this is a patient who's being monitored closely, and the patient truly understands that if there's any change to vision, any subtle change, that's a return back to your clinic for evaluation to, again, further evaluate if there's been a change and now treatment may be indicated.
Yeah, I think otherwise I would just bring this patient back probably within 3 months, repeat the OCT, and geography scan, and just make sure everything's looking stable. And of course, these great cases come in pairs. So I had a very similar case come in last week that I just had to pull the images to show you guys, because I think this is even more subtle choroidal neovascular membrane that I caught with OCT and geography. So this patient did have some subretinal fluid that kind of lingered under the subfoveal space for several months, referred him to a retina specialist, and the only way they could get rid of this fluid was to they tried micro pulse laser, and that failed. They then went on to do argon macular photocoagulation, which finally did dry up most of that fluid on this last examination, which I'm going to show you the raster scans from right here. So as we can see, kind of centrally in the foveal region, there's some photoreceptor loss because of that chronic subretinal fluid that was sitting there. He still has a little pocket of subretinal fluid in the temporal macular region. And right adjacent to that, we have another one of these like Sire lesions or a double layer sign like Mark had mentioned earlier. So I'm already suspicious that this patient potentially has a choroidal neovascular membrane present. So of course I'm going to do OCT and geography, and this is again like a 3 mm by 3 mm scan. So you can imagine like how teeny tiny this neovascular membrane is that's present within that double layer sign. Again, it doesn't change our management of this particular case at this moment, But maybe had we known that when he had this like chronic subretinal fluid, a different treatment approach could have been like an anti-VEGF agent as opposed to, say, macular photocoagulation, which is far more destructive to the retinal tissue. And with that, I'm going to transition into a different topic, which is, near and dear to my heart, proliferative diabetic retinopathy, and be humble and show you things that I missed on my clinical examination that OCT and geography picked up. But I first want to highlight the utility of OCT angiography montage in patients with diabetic retinopathy. So when I do my OCT angiography montage, I'm knitting together 5 8 mm cube scans, which generates for me a 14 by 14 millimeter cube. On the Sierra 6000, you can do a 12 by 12 millimeter cube. So you can get something very similar even just with one shot. But I like to have those extra 2 millimeters in there. And the real value, I think, of this montage in patients with diabetic retinopathy is detecting areas of neovascularization, which tend to occur outside like the arcades, not in the macula, right? They're a little bit further out. And then also imaging retinal non-perfusion, which also tends to be outside the retinal arcades. So this first case is a 43-year-old male who we'd seen previously in our clinic a year ago, was diagnosed with like moderately severe non-proliferative retinopathy. He has type 2 diabetes for nearly 20 years. His vision is good, 20/20 coming in, and this is the Claris Ultra Wide Field photograph here. And I'm going to mag in on the posterior pole findings. And Jessica, Mark, I'd love to ask you, how are you staging this patient's diabetic retinopathy before I'm showing you the OCT angiography montage?
I probably would say severe based on the number of hemorrhages in all four quadrants. Obviously, you're going to probably show us some subtle neovascularization, but just based on the image, I would call it severe.
Agreed. Yep.
Concur. That was exactly my thought as well. Is that, he has some pretty severe dot plot hemorrhages in all four quadrants. And then the OCT angiography montage, and this is the superficial capillary plexus preset, shows what looks like some ERMA in the inferior nasal arcade, and all pretty consistent with severe or very severe non-proliferative diabetic retinopathy. But if we look at I pulled out the 8 mm cube of the montage in the superior temporal arcade, and we look at what we call the VRI or vitreoretinal interface preset. We're looking at blood flow just above the retina. We shouldn't have blood flow in the vitreous. So if something's showing up there, you need to be suspicious that this could be early proliferative disease or pre-retinal neovascularization. And so this patient actually has proliferative diabetic retinopathy that is low risk with an area of neovascularization elsewhere. Even if you didn't have OCT angiography, you can still kind of get the sense just live scanning the posterior pole as to whether neovascularization is present or not. Because it grows outside of the retina and scaffolds on the posterior hyaloid of the vitreous, here we're looking at an area of neovascularization elsewhere on the retina, but we can also sometimes visualize like this hammock hanging across the cup in patients with neovascularization of the disc, and again, proliferative diabetic retinopathy. So what's beautiful about OCT angiography is that we get this volumetric data set and we can segment out particular layers we want to look at. So if all I want to look at is pre-retinal neo, I could say I'm just look at the vitreous. Versus let's say it's ERMA, it wouldn't show up on there. So we have this beautiful opportunity to distinguish between neovascularization elsewhere and say ERMA, intraretinal microvascular abnormalities, using this technology. And there's another case. So how are we going to stage this patient's diabetic retinopathy? A somewhat similar presentation to the initial patient where there's a lot of dot blot hemorrhaging in all four quadrants, some cotton wool spots. I'm sure there's probably some ERMA in there, right? But no like gross area of neovascularization, no gross preretinal or vitreous hemorrhage that's pointing you towards, oh, this is obvious proliferative diabetic retinopathy. But if we look at the OCT angiography montage, that vitreoretinal interface or VRI helps pull out this tiny area of preretinal neovascularization in the inferior temporal arcade. So it makes my job very easy that I can efficiently like pull out this area of neovascularization, know he's proliferative, and then know I need to send this off to a retina specialist for consideration of probably PRP. Here I've just magnified this area of neovascularization for you. I think I took like a 6mm or 3mm scan over that area so that you can appreciate if it's showing up on the vitreoretinal interface, it's neovascularization. If this was just IRMA, it would be within the retina. It wouldn't be up outside, and it wouldn't show up on our vitreoretinal interface preset. So a great tool to help you detect early proliferative diabetic retinopathy. I think I want to highlight two other just really important features of OCT angiography in patients with diabetic retinopathy. The detection of retinal non-perfusion, which for me can just be striking. And this was one of these cases where a type 1 or patient with type 1 diabetes, we can see, I mean, he's got some PRP, but you wouldn't expect that like this whole massive zone is avascular. And yet there's these massive areas of retinal non-perfusion present on OCTA that we can't see with clinical examination alone. So it makes you kind of pause and say, on all these other patients before I had OCT angiography, what was I missing? Like I didn't know that this driver for neovascularization was present. And of course, that retinal non-perfusion can also apply to the macular region. And so when we look at patients with diabetic macular ischemia, they have enlarged and irregular foveally vascular zones in both the superficial and the deep capillary plexus compared to their normal counterparts. But really, the deep capillary plexus is more severely hit and affected in most retinal vascular diseases, that is diabetic retinopathy, as well as like retinal venous occlusive disease. And I'm almost always doing a 3mm scan on the macula if I'm looking specifically for macular ischemia, because I want to get a little bit of a higher resolution image. Any inputs, Jessica and Mark?
I think highlighting the impact of diabetic macular ischemia is so important. These patients with reduced vision, 20/30, 20/40, there's no edema. We know that they're diabetic. Think about macular ischemia as a potential cause. I think one of the other challenges with diabetic macular ischemia is that of all of the excellent therapeutics our retinal surgical colleagues have in treatment of retinal vascular disease, there currently is not a treatment that can reperfuse the macula. So identification of macular ischemia is so important, and this is a real unmet need when we think about treatment options.
And the fact that we're able to image that in our own offices in this high resolution manner without having to do an injection. Even when we were doing fluorescein every single day on these kind of patients, you would never get the kind of resolution and detail that we're able to capture with OCT angiography. So no, those are just beautiful, beautiful images. Thank you, Jessica and Carolyn, for really an interesting discussion and showing just some magnificent, magnificent retinal cases. I think you've seen really the value of OCT angiography in a primary care medical practice. And again, these were pretty straightforward cases for the most part. So again, in patients with retinal vascular disease, to be able to really easily see and understand what's happening on a retinal vascular level in an AMD population, to again be able to see and recognize the presence of choroidal nevascularization. And again, utilizing both what's happening with your OCT B scans and what's happening on a retinal, on the OCT angiography, I think is really valuable. So I think there's great clinical applicability, and also keep in mind that as of 2025, you're getting reimbursed at a higher rate for doing OCT angiography, almost $25 more than you would with traditional OCT. So I think this was really a great discussion. I think it's very timely. And I want to thank both of you for really participating and showing great cases. And of course, want to thank Carl Zeiss for really allowing us to have the platform to be able to talk about this wonderful, great technology. Thank you, everybody.